Hello and welcome to another edition of the Neuro Guru. I'm here with my good friend Drew Carey. Dr. Carey, hello.
Hi, Dr. Lee.
And today we're going to be talking about neuroradiologic findings suggestive of elevated ICP and whether they have a low or a high predictive value for papilledema. And so, Drew, maybe you could just tell the audience why is this even an issue?
Well, I think a lot of patients with chronic headache get an MRI scan ordered by a primary care doctor or their neurologist or somebody. And sometimes the radiologist will look at it and say, oh, there are signs that may be suggestive of elevated intracranial pressure, which triggers an automatic referral to an eye doctor, often a neuro ophthalmologist. But as you may know, and many of our listeners may know, we don't have a lot of neuro-ophthalmologists in the country, and oftentimes it's a very long wait to see one. And so the question is, is this something we need to pay a lot of attention to? Who should the patients be referred to? And just last week, we talked about using AI for detection of or looking at the optic nerve in for fundus photos, and that may tie into this.
And what are the radiographic features that they're finding on these scans?
Yeah, so it depends on the imaging scan, whether it's a CT or an MRI scan. I think the most classic finding is this partially empty sella, which is the bony structure, the sella turcica that holds the pituitary gland, and when there's high pressure inside the head from whatever underlying etiology, the pituitary gland gets flattened and the sella gets expanded over time, as well as some other areas of bony thinning. And it's best appreciated on a sagittal view. Other classic findings can include the vertical dilation and tortuosity of the optic nerve sheath, posterior globe flattening of the ocular globe. In really severe cases, you can see the optic nerve head elevated and protruding into the eye. If you have good imaging of the transverse venous sinuses, either from a MRV, CTV, or just a um, really good coronal view, you can see transverse sinus narrowing. Particularly, it's usually focal stenosis at the junction between the transverse sinus and sigmoid sinus, but it can be more diffuse. Descent of the cerebellar tonsillized, kind of mimicking a Chiari malformation. Those are the big ones that we worry about.
And what would they do in this paper?
So they did a retrospective review looking at all of the new patients referred to neuro-ophthalmology clinic at Emory over the last year, and they said they had around 1,200 new referrals, and then they narrowed those down to patients that were referred for concern of some sort of CSF disorder, and they said that was 247. So it's about a fifth of all their patients, which seems about right, from my experience. And these patients who were referred based on this abnormal MRI, they said there were 66 of them. Patients that were referred from other eye doctors that were concerned about an abnormal disc that might be papilledema was 82. Patients with a previous diagnosis of IIH, maybe referred by neurology, was 83. And then patients concerned for a CSF leak had 16 patients. And then what they did is they looked at, well, what were the findings on the eye exam, and then they had the Emory neuroradiologist overread the MRI scans to see did they agree, where there's more findings suggestive of elevated intracranial pressure, um, and then kind of looked at the outcomes from that standpoint.
And so, what were the results of their work?
Yeah, so just focusing on the patients referred for this radiologic concern for intracranial hypertension. Of those 66 patients, they said 34 of them had actually had prior dilated fundus examinations, which is about half of them. And out of those 34, 9 of them had previously been documented to have papilledema. So these are patients who probably already knew they had IH, and they went to go see a new neurologist for chronic headache who ordered a new MRI scan and said, oh, we got to get you into the ophthalmologist because the MRI is abnormal. And they said out of those 9 patients, actually only 2 of them had papilledema and 7 of them did not, suggesting either it had resolved papilledema or maybe it was an overcall. And the other 25 patients who had not had previous findings of papilledema, 3 of them did have new findings of papilledema, but that was only 12%. And 22 of them had no papilledema, stable eye exams. And then of those patients who'd never had dilated eye exams before, they found 3% had papilledema, or sorry, 3 patients, which is about 9%, and 29 of the patients had no papilledema. 29 out of the 32, so 91% of the patients had no papilledema. So, overall, the findings, not a high rate of papilledema among these patients. Overall, it was 12% of the patients with neuroradiologic findings suggestive of elevated ICP were found to have papilledema. They did do a sub-analysis looking at, well, how many of these findings did did the patients have? And patients who only had one or two, like an empty sella and maybe low-lying, cerebellar tonsils, had a pretty low rate. It was around 5%. But if you had three or more, it increased the rate to threefold, but it was still only around 15, 16%. And so I think for me, this raises the question of, should these patients be going to a neuro ophthalmology clinic for super subspecialty care? Essentially, this is a screening eye exam, right? And I think neuro ophthalmologists are a scarce resource, and we really want them to be seeing, patients that either have vision threatening eye conditions, or they need some expertise for somebody who can look at the eye if there's a question about a diagnosis. Um, and then the other question is, maybe we can use AI to help sort these patients out for triaging, which I think would also be really helpful.
So, what do you think the take home message for our audience is? If your radiologist says they have these findings, are you telling them to go to neuro or general, or don't worry about it?
Yeah, I think the take home finding is, if there's a clinical concern that, they fit the picture, it's, an obese patient, they have pulsatile tinnitus, they have positional headaches, please, send them for an eye exam with, a comprehensive eye doctor that you trust. If that eye doctor has a concern, then certainly get them into a neuro-ophthalmologist. I don't think they need to go to an emergency room for an eye exam. I don't think that they need to be overbooked into a neuro-ophthalmology clinic. If you have a question, you can get that question answered fairly quickly by a comprehensive ophthalmologist. Many neuro-ophthalmologists have 6 week to 6 months waits for new patients, and if you want to answer sooner, go to a comprehensive ophthalmologist.
We're doing the same here in Houston. Well, Dr. Carey, thank you so much again for your time. That concludes yet another edition of the Neurop Guru. We'll see you next week.
Always a pleasure.